Perinatal mental health consultation in the pediatric setting. Presented by Dr. Juliana Finelli and Paulette Carter.
So our next session today is Perinatal Mental Health Consultation in the Pediatric Setting by Paulette Carter and Dr. Juliana Finelli. Just some quick introduction. Paulette is a licensed clinical social worker and currently serves as the Perinatal Infant and Early Childhood Mental Health Consultation Program Manager for the Louisiana Department of Health, Office of Public Health, Bureau of Family Health. Paulette manages an array of programs which utilize mental health consultation as a tool in building the capacity of frontline providers to effectively identify and respond to the mental health needs of their patients. Paulette has over 20 years of experience working in the mental health care field and serves on numerous boards and work groups. She's also an adjunct instructor at the Tulane School of Social Work and a proud mother of two very active teenage daughters. Dr. Finelli is a general psychiatrist and a child and adolescent psychiatrist at Tulane University School of Medicine, specializing in infant and early childhood mental health. She serves as the medical director for the Louisiana Mental Health Perinatal Partnership and supervises trainees at the Tulane Infant Mental Health Services at Metropolitan Human Services District in New Orleans. She also provides mental health consultation to pediatricians for children ages 0 to 6 and their families as part of the Tulane Early Childhood Collaborative. Ladies, I will let you take it away.
Thank you so much. Hopefully everyone can hear me and see the screen okay. We're going to get started. I'm going to be presenting some content and should mention too, because Paulette Carter is our project director for LAMP, but also oversees all of these consultation programs. We've saved ample time at the end of presenting our conference because we'd really love to hear from you. And Paulette has this broader systems knowledge about how all of these consultation programs work. So we'd love to hear from pediatricians about how they feel this kind of consultation program might be most helpful and what the barriers might be. So I first wanted to talk a little bit about perinatal mental health and a little bit about the rationale for why this is important. And I think it's impossible not to talk about the really significant gaps that exist. So firstly, perinatal mental health problems are the most common complication of pregnancy. So the statistic you see cited often is up to 20% of women in the perinatal period. But really importantly, we have to remember among our lower income and minority patients that goes up to 35 to 40%. So there's no question that these are the most common complication of pregnancy. And we'll talk a little bit about why we know that they're a complication of pregnancy and postpartum. But despite this fact, studies suggest that less than 50% of women with perinatal mental health problems are identified by their frontline physician. And even when they are identified, they're undertreated. So 75% of patients experiencing perinatal mental health symptoms actually go untreated. And we know for a fact, it's a simple fact, that we have a workforce issue. There are simply not enough psychiatric providers to care for all the patients with perinatal mental health issues who need care. And finally, pregnant patients are underrepresented both in clinical research. And so that's one of the challenges that we'll talk about in terms of psychiatric providers feeling comfortable treating patients with perinatal mental health problems, but also they're underrepresented in clinical training. And so to expand upon that a little bit, a couple of studies regarding this gap in training, I think it might surprise some physicians and other clinicians who are not in psychiatry. But this was a survey of psychiatry residency training program directors. Only 59% of those surveyed turn out to require any level of training in reproductive psychiatry. And only 40% of those program directors believed that all residents should be competent in the field. And this is despite the fact that at least 50%, often more, of our psychiatric patients are women. Most women will be pregnant at some point in their lives, and all women menstruate. And up to 50% of pregnancies are not planned. And so despite this fact, there's really a gap in terms of training of psychiatrists to feel comfortable in prescribing for patients in pregnancy and postpartum and identifying perinatal mental health problems. The good news is that fellowship training in reproductive psychiatry has grown significantly, even just in the past 15 years. The subspecialty, though, is still not a recognized subspecialty by the American Board of Psychiatry and Neurology. so that we still have further progress to make. And on the other side, looking at other clinicians who are treating these patients, specifically OBGYNs. So this study surveyed OBGYN residency program directors. Only 19% of those program directors agreed that their residents were equipped to identify their patients' psychiatric needs. And the most commonly cited barrier among those program directors was lack of integration between OBGYN and psychiatry. So I know we'll be talking about the pediatric setting, but I think it's important to think about what our colleagues in other fields are doing and what the comfort level is among our colleagues who are caring for these patients and their families. So we're going to be talking a lot during this conference about ACEs. I know there's already been discussion around ACEs, and then we'll be talking tomorrow even further about ACEs, and Laura Alderman gave a presentation. But it's important to remember here, talking about perinatal mental health needs, that among those ACEs, mental illness, so a household member with mental illness, mother being treated violently, so intimate partner violence, and substance abuse in the household are all considered ACEs. And so these are all areas more specifically where perinatal mental health consultation can intervene and address those issues. I also want to mention here, although we won't necessarily have time to go fully into this discussion, but when we're thinking about ACEs too, we're also thinking about our perinatal patients and their experience of early childhood adversity and how that impacts their mental health and well-being, and how their mental health and well-being is impacting actually the prenatal environment and potentially causing epigenetic changes that are going to impact development. So definitely when we talk about perinatal mental health, we're always talking about 2 generations, if not more. So a little bit about screening, because we're going to spend some time talking about screening. When I talk a little bit more about the specifics of our program, one of our mandates from HRSA, our funder, and of course, one of the things we really are one of our goals is to increase universal screening for depression, anxiety, and substance use disorders in the perinatal period. And so a little bit just about screening, and of course, folks working in pediatrics know more about screening than many physicians in other fields. But in medicine, we screen for disorders that are prevalent, that are identifiable with low-cost measures, that cause impairment, and finally, that are treatable. So we're going to talk a little bit about the specifics here in perinatal mental health. So regarding prevalence, no question that perinatal mental health problems are prevalent. They're the most common complication of pregnancy, as we said. There also are identifiable with low-cost measures. So there are free, non-proprietary self-report measures. All of them are short. They're completed by patients. Scoring them takes less than 3 minutes. So those first 2 criteria are met. When it comes to do they cause impairment, there's also no question that perinatal mental health problems cause impairment, both when it comes to pregnancy, so less adherence to medical recommendations and prenatal visits, but also preterm birth, low birth weight, emergency C-section, maternal suicide, and infant outcomes. There's plenty of data looking at social outcomes, so less interactive socially, more difficult to calm, actual biological changes, including EEG asymmetry, low vagal tone, abnormal catecholamine excretion. So we have plenty of data to support that perinatal mental health problems absolutely cause impairment, but also parenting challenges. So studies have found that parents with mental health issues have reported feeling less competent, have been observed to have more irritable or disengaged interactions or fewer interactions overall. The impact on health patterns. So for example, lower rates of breastfeeding persistence have been found for mothers with perinatal depression, difficulty with timely well child care and immunizations, use of safety measures, including things like car seats and smoke detectors, and then also higher rates of corporal punishment in children. And then we also have observed negative outcomes in infants. So studies even at 9 months finding reduced social engagement, more expressed fear and negativity observed. And then in toddlers and adolescents as well. So higher risk for internalizing problems and higher risk for externalizing problems. And finally, moving past impairment to talking about about treatment, and we screen for disorders that are treatable, there's plenty of evidence to support the efficacy of screening itself, actually. There is some evidence to support the benefits of screening in and of itself, but certainly for supportive approaches, psychotherapy, and medications. So thinking about our colleagues and what our colleagues are doing in OBGYN, so the American College of Obstetrics and Gynecology recommends screening at least once during the perinatal period for depression, and anxiety using a standardized validated tool. They also recommend a full assessment of mood and emotional well-being, including screening for depression and anxiety during that comprehensive postpartum visit, which is sometimes at 6 weeks postpartum, but not always. The challenge here is that many women actually do not keep their comprehensive postpartum visit. Depression may present earlier. Depression certainly may present later than that 6-week postpartum visit. And perinatal depression itself is associated with missed appointments. And so if we're only relying on screening in the OBGYN setting, it's likely to be insufficient. We also know that while we're very happy that ACOG is recommending screening at least once in the perinatal period, it's likely not enough, and women actually should be screened multiple times in pregnancy. So it's possible that a patient was screened in her first trimester and didn't develop symptoms until the second or third trimester, and maybe has not had anyone screen her at this point, during her pregnancy. So this is part of why the AAP recommends screening for maternal depression at the 1, 2, 4, and 6 month well baby visits. Also, the AAP also recommends a psychosocial assessment at every visit with attention to poverty and behavioral health. And when it comes to the pediatrician's role, because I think this is something that isn't always clear, really the pediatrician's role is certainly one of screening and of referral. So primarily screening and referral to specialty care rather than treatment. However, when the patient actually is the mother, so in the case of an adolescent patient who becomes pregnant and has a baby, the pediatrician's role may be implementing first-line treatment, including potentially medications to treat depression or anxiety. And just to add here about Louisiana's screening guidelines, and these can be found on the LDH website as well. I'm sure everyone has seen this, including the screening toolkit, but just a reminder too of the screening instruments that have been recommended by LDH for screening for perinatal depression, again, at those 1, 2, 4, and 6 month visits. So when we're talking about consultation, we've talked a little bit about screening, and one of the roles of consultation is to promote screening. And we'll talk about the other things that we do in consultation. But the first question is why consultation? So why provide mental health consultation to primary care physicians and frontline clinicians? So the obvious answer, it sounds simple, but it's true, is that that's where the patients are. So women see a frontline healthcare clinician, whether it's their OB, their pediatrician, or their primary care doctor 20 to 25 times during that perinatal period. It's a time of increased healthcare utilization, no question. And thinking about children, 95% of children in the US have health insurance. And in those first 5 years, 15 scheduled visits, so not even counting those sick visits where children are also presenting to their pediatrician. So there's a huge window of opportunity at a high risk time for mothers and parents who might be experiencing mental health problems in the perinatal period. But furthermore, frontline healthcare clinicians, including pediatricians, are trusted experts. They have relationships over time with patients and their families, and families trust their pediatrician. They go to their pediatrician when they have a question. Finally, consultation can leverage what we've already discussed are very scarce psychiatric resources. So we already talked about we have a workforce problem. We simply do not have enough psychiatrists to care for all these patients. So with support, training, and resources, those frontline healthcare clinicians can manage mild to moderate mental health concerns, then creating the opportunity for those more complex patients to be managed by specialists. So just to give a little visual of the rationale behind consultation, imagining a perinatal psychiatrist, of which we have a handful, just a handful here in Louisiana. We have some wonderful perinatal psychiatrists, but really a small number. So if a perinatal psychiatrist is just providing direct services, she may have a caseload of 200 to 250 patients a year that she's caring for. But imagining if that perinatal expert can provide consultation to frontline healthcare clinicians, including pediatricians and OBGYNs and family medicine physicians, the reach of that expertise becomes so much broader because of all the additional patients she's able to reach through that expertise. Because by providing consultation, it's not just for that individual patient, but it's enhancing the capacity of that frontline clinician to identify, manage, and refer. And then if we want to take it a step further, because we're talking about the pediatric world, we think about all the children that are impacted by that consultation, knowing that most families have more than one child, that our impact is even broader, providing this form of consultation. So that's really the rationale behind consultation, is sort of getting out of our silos and going beyond direct services to enhance the reach of that training and expertise. So a little bit generally about what's going on in the rest of the country, because there are perinatal psychiatry access programs across the country. The states with the dollar sign are the states that have received federal funding from HRSA, including Louisiana. We're one of 7 states. And then the states that, there are other states, as you can see in dark purple, who already have consultation programs that are funded through different sources. And then there are a number of states who are also working to launch perinatal psychiatry access programs. So there's a movement across the country promoting this type of consultation program to address this gap in care. So a little bit about LAMP and our program, Louisiana Mental Health Perinatal Partnership. So among healthcare clinicians who care for pregnant and postpartum patients and their families, to increase universal screening, as I mentioned. Primarily for depression, anxiety, and substance use disorders, we've added intimate partner violence to that goal because it's so common, and because it's a common cause of pregnancy-associated death is homicide in the state of Louisiana. And so we wanted to make sure that we also address screening and resources and support for intimate partner violence. We also want to increase early detection, evidence-informed first-line management, and referral to specialty evidence-based treatments as needed. So we're not just only doing referral, we're also supporting implementing some of those first-line interventions when appropriate and when possible. We support referral and connection to services, treatment, recovery support in underserved and rural areas of Louisiana, so across the state. But also basic needs resources as well. And then always our plan is to develop a plan for sustainability so that we can continue providing these services. This is a 5-year HRSA-funded program. We're currently in our 3rd year of funding. And so this is something we're actively working on, is thinking about sustainability and what are the elements of this program that will be most beneficial to our state. So a little bit about the components of what we do. So the most important, the primary thing that we do is we provide statewide phone consultation to any healthcare clinician in the state. So this is clinician to clinician consultation, like curbside consultation is another way to think of it. So any healthcare clinician in the state can call with a general question about screening, with a patient-specific question about diagnosis, treatment, next steps, safety, medications. So that's the primary role of our program. We provide full-time resource and referral phone consultation. So a provider can call us and ask for, I need to know where to send my patient who needs substance use disorder counseling and support, and we can provide tailored resource and referral for that patient. We also have real-time psychiatric consultation. So currently about 30 hours a week, and I'd say it's generally real-time, but certainly within the day. On the days that we don't have full coverage, we provide psychiatric consultation. So a prescriber can ask a question regarding risks and benefits of medication, side effects, dosing, titration, all of those questions. We want to provide support for that. Knowing, again, that OBGYNs don't necessarily receive training in psychiatry, nor do family medicine physicians receive a significant amount of training. And so we want to be able to provide that support. We do a lot of trainings. So a big part of what we do is trainings, which in the days of COVID are primarily virtual trainings like this one. We record all our webinars, so we don't put any barriers in place so anyone can access them for free. And finally, we have a website with a number of clinical tools, including clinical tools developed by MPAP for Moms, which is itself modeled after MCPAP in Massachusetts, the Child Psychiatry Access Program. They're the program after which ours is modeled. So a lot of their resources, but also our own clinical tools, and we have a searchable resource database. So the idea here is that for any parish in the state and any given insurance provider and the patient's pregnancy status, so whether she's first, second, or third trimester or postpartum, what resources can serve her. So we maintain a pretty tailored list of mental health resources, but also basic needs, infant mental health resources, et cetera. We do provide some on-site mental health consultation, again, when we're not in the midst of a pandemic. So in regions 1 here in New Orleans, but also in region 4 in Lafayette, and in region 8 up in the Monroe area, we provide some on-site mental health consultation. And then we can offer some telehealth consultation with patients in selected cases. Of course, we have a little bit less capacity to do that because we provide statewide consultation, but that is something that we're able to offer as well. So just to mention our leadership, again, you've met or seen Paulette Carter, who's going to be talking more, who is our project director at BFH. And then a little bit about kind of what this looks like. So the idea behind our model is that any perinatal partner, any healthcare clinician, again, as I mentioned, the state calls our direct line. If it's a resource question, they get an immediate response from our resource specialist or our mental health clinicians, and then we provide a written summary of that information. We don't provide services directly to patients, so we can't take over care management of patients. At this point in our program, we're not funded to provide care coordination, but what we can do is provide some really specific resource information. A lot of what we hear from primary care physicians is, I don't know where to send this patient. There aren't enough mental health clinics that will accept or treat pregnant or postpartum patients. And so we find that information out. So we call the clinics in the state and we find out what the details are so that we do some of the work for the clinician so that they don't have to make those phone calls. We also coordinate with a lot of community agencies. And so we are familiar with kind of trusted sources, so trusted mental health clinics where we've heard feedback that patients have had positive experiences, for example. So we're trying to sort of bridge that gap of getting patients to specialty care when they need it. If there's a clinical question, so if there's a question regarding diagnosis, safety, certainly medications, then the caller is connected with one of our psychiatrists, and we can provide that real-time support to answer those questions. So an example of some of the questions that we get from pediatricians, because we get consults from pediatricians quite frequently. So for example, these are all actual consults, a mom who came for her baby's first well visit and was crying inconsolably in the exam room. And we got called, what should we do? How can we offer her support? And so then the discussion was around screening, around differentiating between baby blues and postpartum depression, providing psychoeducation, timely follow-up, and a series of next steps of if-thens, kind of next steps. And we actually ended up getting a follow-up too, and we're able to follow up with this case. So that's an example of one question that we get. Another consult question we received was a parent who was breastfeeding. So she was there for her well baby visit. Breastfeeding, is also on psychiatric medications, and asked her pediatrician, her trusted pediatrician, what should I do? I'm concerned about the safety of these medications in pregnancy. And so there we were providing guidance around what case reports exist, what the sort of sum of the available data is regarding safety and breastfeeding, different considerations, also just general information regarding breastfeeding and sleep and the importance of sleep hygiene in the postpartum period, and what to do next so also screening and monitoring mood, given that she's on psychiatric medications, perhaps more frequently. So that was a question that we received as well. Another question we received from a pediatrician was just around, this parent is really stressed, and I see a lot of stressed parents, but I'm not sure if this is normal parenting stress or if there's something maybe more serious going on. And so there we talked about screening, we talked about differential and things to consider, we talked about safety, and we talked actually in this case about parenting supports. So all the way from Postpartum Support International's virtual support groups, which are free for parents, all the way to specific interventions, so infant mental health services. What we have found, I have found in providing consultation, perinatal consultation, but also consultation in the pediatric setting for early childhood concerns, is that pediatricians are really good at identifying when there's something wrong, and are really good at getting a gut sense for things. And so sometimes the call we get is, I'm not sure what's going on, but there's something that's not quite right. And we really welcome those calls. That's exactly what we want to be able to help and provide support with. And finally, we also get calls with questions about, how do I implement screening? We want to do this. We want to incorporate maternal depression screening. How can we do this? What are the steps? And so we can provide some technical assistance in that setting about screening, who can administer the screen, who scores it, how to give feedback about positive screens, how to give feedback about negative screens. So just kind of some of the questions we've gotten, just to give you sort of a sense of what happens when folks call. And a little bit about screening too. So some of what we do is provide some really direct assistance around screening and how to administer the screen, how to score and interpret it. And among recommended screens, just kind of touching on some of the screens that we see being used in the pediatric setting, including the EPDS, the Edinburgh Postnatal Depression Scale, the PHQ-9, and the SWYC, which includes in it actually the EPDS. So just to mention briefly about kind of what we're doing with our website and how we're trying to support consultation, even when providers don't call us, so they know where to go to get the resources. So on our website, we have a number of clinical handouts, so including a handout about SSRI, sort of a cheat sheet, specifically with some considerations in pregnancy and breastfeeding. A cheat sheet about how to talk to patients about risks and benefits of SSRIs, for example, which are commonly prescribed for depression, anxiety in the perinatal period, how to weigh risks and benefits and how to have those discussions. That's a question we often get. And then finally, we talk a lot about sleep. I don't have all the handouts on here. We have a handout about sleep hygiene in pregnancy. We also have handouts regarding like understanding infant cues, and some tips for consoling an infant, all of which is also geared towards healthy sleep, not just for infant, but also for the parents and for their well-being. So those are some of the kind of handouts that we provide. They're geared towards providers to give them guidance about next steps and how to talk about these issues with their patients. And then, as I mentioned, our webinars we put up on our website. So our webinars really are broad. They're all focused on perinatal mental health. Some are more focused on medication, psychopharmacology questions. Some are more focused on, for example, ACEs or perinatal grief and loss, differential diagnoses of various disorders in the perinatal period. And all of those are available for free on our website. And finally, the resource database that I mentioned, our idea is to try to provide as tailored resource support as we can. So we encourage providers to call us because we can also just do this for them and give them a list of 3 next clinics to call. These are the 3 clinics to refer this patient to, but also clinicians can look this information up themselves based on pregnancy status, language the patient speaks, whether they're insured by Medicaid, private insurance, et cetera. So we have a number of different resources, a pretty extensive resource database that's continually growing and that we're always adding to and updating, especially in the midst of COVID with so many changes. I wanted to mention too, I know we've been talking specifically about this perinatal mental health consultation program, but I wanted to mention too, just the fact that we're trying in consultation, and Paulette could speak more to this, to just create multiple doors to accessing this support and these services. So I mentioned this other program, the Tulane Early Childhood Collaborative, which the clinical director is Sarah Hinshaw-Fuselier, who will also be talking in this conference, and I think is talking next. But the goal of TECH is really, it's focused on early childhood, so kids 0 to 6, and promoting early childhood well-being and supporting pediatricians, but also included in that is supporting parent mental health and well-being. So there's significant overlap in our consultation programs. And so sometimes providers aren't sure, well, who am I supposed to call? But the truth is there's multiple doors for accessing these kinds of supports and services. And so one of the things that Paulette is doing at the state level and that we talk about often is about coordinating between these various consultation programs. We get a lot of consults. We work a lot with home visiting programs. So trying to kind of break down these silos and collaborate. So I just wanted to mention that as well. There's a lot of doorways to getting support with maternal depression screening. So a little bit briefly, and I'm trying to keep track of time. I know we started at a slightly different time, but so just to give you a little bit of information about who's using our program, because we'd love to get your feedback. As you can see, we have a smaller percentage of pediatricians who are using it, and that's partly because our program has very much been targeting OBGYNs and family medicine physicians. But we do have a number of pediatricians who are engaged in our program, and we do get a number of consults from pediatricians. We're always looking to expand the number of frontline healthcare clinicians who are using it. So we'd love to get your thought and your input. In terms of we administer a survey, a brief survey to folks who are willing to complete it, who use our consultation program, about their perception of resources in the state. And I think this is really telling that such high percentage of our respondents, and this is across healthcare fields, are reporting either inadequate or grossly inadequate resources for mental health, including psychiatrists who are able to prescribe for pregnant patients. So we're seeing pretty high rates of physicians and other clinicians reporting lack of resources. And we think probably a couple things are going on. We think one is actual that we don't have enough resources, and that is true. But I think it also reflects, in some cases, a lack of awareness of certain resources. So for example, a lot of our respondents are saying that they feel there's inadequate or grossly inadequate availability of non-clinical supports like home visiting. And home visiting is available across the state. And so we want to make sure that we are enhancing awareness and use of those programs that exist and that have an excellent evidence base. And then also with case management for basic needs, we also think a lot of providers aren't aware that, for example, in pregnancy, the managed care organizations, Medicaid managed care organizations in the state provide case management for pregnant patients. So one of our roles as a consultation program is to make sure that we get out the awareness of those programs that do exist. And then when it comes to substance use disorders, even higher percentages of reports of feeling like a lack of adequate resources for pregnant and postpartum patients, but also fewer are reporting feeling comfortable managing substance use disorders and other concerns related to substance use disorders. Finally, I'll just add here too, although, as I mentioned, our percentage of pediatricians the number of pediatricians enrolled in our program is maybe lower than our other provider types, but we get a number of consults from pediatricians. So we are being used by those pediatricians who are engaged in our program, which hopefully means that we're doing something helpful. So finally, I'm going to turn this over to Paulette to kind of add a little bit about the larger systems issues. And we'd love to get some feedback also from all of you.
Thanks, Juliana. And I think Dr. Finelli definitely made a case for mental health consultation, and the Bureau of Family Health has done a lot is doing a lot now and in previous years to really ensure that this is a program that can be accessible statewide. And for those of you who don't know, I mean, the Bureau of Family Health definitely has, implemented mental health consultation in its home visiting programs. So with the Nurse Family Partnership and Parents as Teachers programs, if you're familiar, we do have consultants working with those home visitors to, help them address the mental health needs of the parents and the children that they're encountering in those programs. And we really feel like this is an important program for any frontline provider, including sort of pediatricians, OBGYNs. Certainly Dr. Finelli talked about LAMP and the services available through there. We've also provided some mental health consultation in Regions 4 and Region 5 for early steps programs, as well as pediatric primary care. And we're hoping to also, we have a grant application into HRSA right now to really expand mental health consultation statewide for pediatric primary care providers. So we're hoping in the next few weeks, we might get some positive news from HRSA that's been awarded. And so hopefully you'll see us a little bit more across the state and really working to implement mental health consultation within pediatric primary care. So I think one of the things that we're trying to do a lot of now is really trying to get feedback from providers to kind of understand what is useful to providers when it comes to mental health consultation, what might be some of those barriers that might, prevent you from using mental health consultation, what are those program elements that are key for you, and so what we wanted to do is take a little bit of time today, and we can do this in the chat. If you can put some of your answers in the chat, would be really helpful. It's just to kind of get an idea from the participants, like what are some of those barriers that exist that might prevent you from using a mental health consultation program like, LAMP, which was described by Dr. Finelli, or TEC, or a sort of pediatric primary care mental health consultation program. And so if you could just, again, this feedback is crucial as we sort of try to really think about how do we develop these programs statewide and make sure that all providers have access to these great resources. So if you could type in at this point what you think are some of the barriers that might prevent you from using a mental health consultation program. And we'll give you a few seconds to kind of type that in, or if you have any other questions, I think this is a great time. I think we have about 5 to 10 minutes left on this presentation. So if you have any questions regarding the material that Dr. Finelli presented to, please start typing those in as well. And Dr. Finelli, I wonder if you might want to sort of talk about some of the things. I know you've talked to lots of different providers, in regards to sort of mental health consultation. And, I think some of the things that LAMP has done to really kind of address some of those barriers. I think one is it's, having psychiatric consultation available pretty much almost 40 hours a week. I think you said 30 hours a week, making sure that there's sort of these, again, I think having a comprehensive list of services, whether it's psychiatric consultation or resources, access to resource database, et cetera. I don't know if you want to kind of sort of talk about some of those things that you've done to sort of try to break down those barriers.
Yeah, sure. I mean, we have, and it looks like we do have a comment in the chat, so I'll get to that too. So thank you for sharing that. So I think one of the things that we're finding is, one is just clinic flow, and that both OBGYNs and pediatricians are some of the busiest physicians out there. And so I think one of the challenges is just the timing factor. And so one thing we have found is that when we have provided some on-site consultation, we have found that providers are thinking of, they're saying, oh, hey, yes, Dr. Finelli, you reminded me, I had a question from last week. I saw this patient. And so there's this ease of kind of having someone right there to answer your question. So we've been trying to recreate that through providing a telephone consultation. And that's been a bit of a challenge to try to kind of recreate that. We try to make ourselves as available as possible. I should mention too, I think sometimes there's concern that it's going to take too much time. Our average length of a phone call is about 8 minutes, give or take. So some are shorter than that, some are a little bit longer, but it's definitely under 10 minutes. Sometimes it's as short as 5 minutes because we know how busy you are. And so we're not trying to turn a pediatrician into a psychiatrist, but try to give quick, immediate responses to the questions they have and maybe a few next steps. It looks like the question here in the chat, which is a great one. Thank you so much. Don't have as much time as I'd like in well visits to discuss mom's mental health. So it often becomes you should follow up with your OBGYN if there's a positive postpartum screen. And that's probably the biggest barrier. That makes perfect sense. Absolutely. And one of the challenges too is that sometimes, especially even after that comprehensive postpartum visit, women stop seeing their OBGYN and they don't always resume care with their primary care physician. So there's this gap that is created there where they get all of this healthcare, and then kind of after they deliver, things change. And so I think there have been some efforts, at the federal level and the state level to address that and make sure that women can continue their care after they deliver. I think one of the challenges is then the person they see the most is their pediatrician. They come to well baby visits and might not go to any of their own healthcare visits at that point. I don't know, Paulette, if you have any thoughts about that from a systems perspective.
Yeah, and I think that, we've encountered a lot. I think, there's so many different providers involved in the care of a birthing person. So from pregnancy to the birth to, really kind of the pediatric care following that, the well baby visits. And I think that there is, some trying to figure out, who does what and making sure that there's like this seamless sort of transition in care between those providers. And I think what I've seen is in my conversations with providers recently is that people really start thinking about this. So how do we make sure that there is follow-up with this patient, with this caregiver ongoing? And I think it's, again, I think doing some of the perinatal depression screening, in pediatric practices is really also allows that to happen. Because again, like you pointed out earlier, that's where the patients are, right? And a mom, honestly, or a caregiver is going to be more likely to go to their well baby visit than they are going to be to go to, to their primary care physician. So just making sure that we're really trying to capture that. And I think a key part of mental health consultation is also helping providers think through, how do you integrate this into the flow? What does this look like, right? And then how do you communicate this information to those other providers, whether it's a specialty behavioral health provider or their PCP, or, how do you then communicate this information so that there really is this team working with this caregiver to ensure that they're getting what they need, which we know, again, really definitely impacts the health and development of that child as well. So
I'm so glad you brought that up, because you reminded me to mention the screening passport. Which is really comes from the world of pediatrics, but the idea is that it's the screening passport so that patients can kind of take ownership of their screening results. So sometimes that communication piece, because we've all tried it, and having to call, playing phone tag, trying to get the information, got to get the consent signed. There's a lot of barriers to that kind of cross-disciplinary communication. The idea with the screening passport is that patients can keep their own screening results with them. And it's a brochure that also has LAMP's resource phone number in case their provider wants to call us, but also a number of other resources for the patient and for the clinician, so they can take it to their primary care provider. And it's a way of helping kind of cross, that communication. So they're getting screened in the pediatric setting, so that we're sure that their primary care provider is also seeing that as well. So it's one kind of idea and solution that we put in place that our home visiting folks have used as well. So it's a really important barrier. It's something that we're finding as well, and we're trying to figure out creative ways to address it.
And I think also just trying to empower, again, the patient to be able to have this information and to share it, and have a platform, that they can use to share that information with their physicians, whether it's the pediatrician or the OBGYN or the PCP. It's a great way. They may not necessarily know how to say it on their own, but this passport really gives them an easy way of providing that information to their clinicians. Absolutely. The next question that we had on here is just kind of, really thinking about, what are those elements? What is it that you need as a provider, as a pediatrician? What is helpful to you to have access in a mental health consultation program? Does this, is it 24/7? Is it, is it, after hours, psychiatric consultation that you need? Is it more about resources and care coordination for your patients? Just kind of curious about, what's going to really help you to say, yes, that's what I need to call, or I need to seek consultation on this particular issue, because this is what I need. And if anybody can, again, put this in the chat, would be awesome. I think, again, Dr. Finelli has talked a lot about sort of how we've sort of anticipated some of those things with LAMP, and trying to make sure that we do have easy access. Certainly, the telephone access statewide, and I know as a provider, in my past life, just how important it was, those questions that you have, to be able to have a real-time answer to those questions. So I don't know if anybody wants to put anything into the chat for that. In the meantime, I'm actually going to put something in the chat for everybody, to just a link to a survey that we're doing. We're trying to also figure out how we can support pediatricians in implementing sort of the caregiver depression screening. Again, we know that is now reimbursable through Medicaid. And we understand also it's again, trying to integrate it into your practice, and to make sure that you are able to have a list of resources to which to refer caregivers should they screen positive, is always a challenge, but we want to make sure that we're supporting you. So I'm going to put a link to a survey in the chat. We're just, again, trying to collect more information from providers, really get your insight on these things, so that we can develop programs, through the Bureau of Family Health, that really do are able to kind of meet your needs when it comes to maternal depression screening. So I just put that in the chat, although it didn't let me put anything else in there, but I will put it in there again and describe what it is. But you can just, go to that link. It will, take you to a survey so that we can get some of your feedback. And I will also let you know, just in the future, as we develop in these programs, we'll be reaching out to, to providers really across the state to get your feedback, because we realize just how important it is to have your ideas and your insight in the development of these programs, which really are meant to support you in the work that you're already doing.
So I think we are probably coming up on time, but if any, of course, please do reach out. I'll put my email in the chat as well, or you can email Paulette, but we'd love to hear from you. We'll be around through the conference. So we just love, if you have questions, comments, input, ideas, we'd really love to hear from you.
Thank you.
Thank you so much, Dr. Finelli and Paulette. I really appreciate it. That is a wealth of information and resources.
Scan the QR code or go directly to the link to complete the evaluation and claim education credit after viewing all the presentations. Please reach out if you have any additional questions or if you need any assistance.